Sam's trying to get, but we'll go ahead and get started. So if you could go to the next slide, Stacy, that would be awesome. So there's going to be 4 of us presenting today, and I'm going to introduce myself, and then I'll let Demia introduce her, and Martine introduce, and then Sam. So I'm Diane Halo. I am the program director here at Greater Columbia. Demia.
Good morning, everyone. My name is Demia Safford, and I'm the Jedi Specialist at Greater Columbia.
And Martine.
Good morning, everybody. I'm Martin Sanchez. I'm a Senior Practice Transformation Navigator with Greater Columbia.
Great. And Sam, are you on yet? She was having problems getting on. So she's the Director of Practice Transformation. Could you go to the next slide? Okay, so I really want to get to know each other a little bit as we go through this. So we're going to do a whiteboard activity. And so we're going to have, the question is, if you are going to serve a visitor a meal that would help them understand your cultural heritage, what meal would you serve? So Stacy's going to put a whiteboard up, and I will tell you how to use it. So up at the top of your thing where it says view options, if you go down to annotate and you click on that, there's the options to use a text or draw or anything like that. So so let's just all start. I'll start. For me, it would probably be meat and potatoes, just because of my dad and mom, and that's kind of what we grew up on. So tacos, yes, tacos, definitely. Pozole, black-eyed peas, pot roast and mashed potatoes. Someone said corn, soupy beans and cornbread. Corned beef and cabbage, yum, I love that. Veggie burger, baked potatoes. Let's see, beans, tortillas, and red mozzarella, the real kind. This is so fun. What about some Southern? Is there some Southern stuff? I know we would definitely have that if Sam were on. I don't even know how to pronounce. How do you pronounce the one in red?
It is krautbro, and what it is a homemade pocket of bread with hamburger and cabbage in it. It's amazing. With some butter on it. It's a yummy little roll.
Yum. Let's see. Biscuits and gravy. It looks like some people are using the chat as well. Steak. Chili. And you can feel free to unmute yourself if you'd like to do that as well and say it. St. Louis style pizza. Chili dogs, hot dogs and chili. Beef brisket and German potato salad. I love this activity because it shows that there's so many different things that that it shows, you know, what you've grown up with, and everyone has different things that they would consider their, you know, the food of choice if they had a chance. And a lot of it sometimes is part of our culture and what we're brought up with. And so this just kind of shows that, you know, we even with our food, culture comes into play with it. So we'll go ahead and thank you so much for participating. It looks like other people put fish and chips in the chat as well. But yeah, so if we could go to the next slide, Stacy, thank you so much for participating. I really appreciate it. So today this is going to be our training goal for today. And the training goal is we're going to talk about defining health equity. We're going to learn to understand unconscious bias in healthcare. We're going to define the culture and cultural competence. We're going to explain 3 benefits of clear communication. We're going to explore and understand the LGBTQ, the gay, lesbian, gay, bisexual, and transgender communities. And we're going to address healthcare for refugees and immigrants. And then we're also going to reflect on strategies when working with seniors and people with disabilities. So next slide, please. So I'll let Damia take it away.
All righty, everyone. Thanks for joining. So I'm going to start off with, can you move to the next slide, please? Thank you. Health equity. Health equity is a state of being where a person has the best chance to reach their full potential, regardless of identity, environment, or experiences. How do we achieve this? We achieve health equity where institutions support every person in achieving their individual full health potential so that no person experiences negative health outcomes as a result of identity, environment, or experiences. Next slide, please. Health disparity versus health inequity. I know they sound familiar, but there is a difference. First, health disparity is any difference in health outcomes between 2 groups of people, whereas health inequity is any difference in health outcomes between 2 groups of people that is immoral or unjust. Now we're going to cover a little bit about unconscious biases in the healthcare. All right, move something over here really quick. What is unconscious bias, you may think? Unconscious, also known as implicit biases, occur when the automatic processing is influenced by stereotypes, and therefore stereotypes impact your actions or your decisions. And I have something here I want to share with you really quick. Let's see here. So every moment your brain processes incredible amounts of information. This processing allows you to function, to make decisions, and also take actions. The majority of this goes on behind the scenes, which is a necessary efficiency that means you don't have to think about most of your activity, such as breathing. I'm sorry, what was that?
Go ahead. I think she just, go ahead. Keep going, Damia.
Okay,
Sorry about.
For example, the minute calculations your brain makes to accomplish simple things like walking across the room to open a door, or more complicated things like accessing a fellow human being, your brain is able to process situations quickly because it relies on what it already knows or think that it knows. Your memories help your brain categorize and sort information so it can be quickly analyzed without your awareness. So basically, we do a lot of things without even being conscious of it. All of your experiences and impressions inform your current actions and help your brain make automatic conclusions. Research shows that your brain makes decisions upon every 10 seconds before you even realize it. This indicates that most of your conscious decisions are really unconscious, leaving you with limited space for free will and decision making. So instead, your brain reaches conclusions based on what is already familiar, safe, likable, valuable, and logical. Let's talk a little bit about stereotypes. What are stereotypes? A stereotype is a belief that associates a group of people with certain traits or characteristics. A stereotype is also a prejudgment of a person based on a group that he or she may be associated with. Stereotypes tend to be fixed and oversimplified images or ideas. As you see the picture here, there's a lot of things, stereotypes. Everyone is different. This person is blonde. This is a ginger, fat, dumb, jock, things like that. Those are considered stereotypes. For example, elderly people are bad tippers. And you may have encountered this before. I've heard these stereotypes before. Asian people are good at math. Women like to talk a lot, or women are catty. Gay men are flamboyant. Black people are athletic. So the list can go on and on with stereotypes that many people may have. All right, next slide, please. And next, we're going to watch a video. We're going to talk a little bit about, I want you to watch this video and put your questions in the chat after you watch the video, and we can talk about it. So how boring would the world be? All right, thanks, Stacey.
It's easy to put people in boxes. There's us, and there's them. The high earners, and those just getting by. Those we trust, and those we try to avoid. There's the new Danes, and those who've always been here. The people from the countryside, and those who've never seen a cow. The religious, and the self-confident. There are those we share something with, and those we don't share anything with.
Velkommen. Jeg kommer til at stille jer nogle spørgsmål i dag. Nogle af dem kan godt være lidt personlige, men jeg håber, I vil svare ærligt på dem. Hvem herinde i rummet var klassens klovn? Hvem er bonusforældre?
And then suddenly, there's us. We who believe in life after death. We who've seen UFOs. And all of us who love to dance. We who've been bullied. And we who've bullied others. And then there's us, the lucky ones who've had sex this past week. We who are broken-hearted. We who are madly in love. We who feel lonely. We who are bisexual. And we who acknowledge the courage of others. We who have found the meaning of life. And we who have saved lives. And then there's all of us who just love Denmark. So maybe there's more that brings us together than we think. TV2 Denmark. All that we share.
Friends would walk up to me and just
All right. Hope everyone enjoyed the video and got something, a little takeaway from that. Next slide, please. So now we're going to have our breakout rooms, and we have 3 questions listed here. Everyone's going to be divided into groups. If you can just jot down this question here, it may be in the chat, excuse me, or you may see it in your break room. If not, just pop something in the chat if you feel like you don't have the question or can't write it down fast enough.
Chelsea, can you put Stacy, can you put them in the chat real quick? And then if everybody could just like copy them so that when we go into the breakout room, at least somebody will have them. That would be awesome. Thank you.
Thanks, Stacy.
Okay, so everybody should have that in the questions in the chat. I'm going to open the breakout rooms. I've had it occasionally happen where sometimes the questions don't stay. So if you guys have issues, I am reachable back here in the main room. So if you need the questions sent again, I can send them. So I'm going to open those rooms now.
Does it automatically send you to the room, Stacy?
Yes.
Okay. It looks like everybody's in there. Can you move me into one, and then Ed needs to be moved into one?
Yeah, I'm trying to get him to. Okay.
There.
So.
You can leave me out. It doesn't matter.
Okay, yeah, it doesn't look like.
There's a couple people. Rachel, we're doing a breakout room right now, you guys. So we'll put you in one of the rooms.
It's like people are popping out.
Poor Ed. We're sorry, Ed. Let's try to put him in number 9, maybe.
I'm like, trying. It's like he's assigned, but for some reason it just keeps saying not joined. I don't know why.
He might be away from his computer or something.
Yeah.
Sam can't get on.
The question to room 6. Okay, so Heidi asked for the room to be sent to room, or question to be posted to room 6.
Ed, you're, oh yeah, he just went into room 9. We have 2 more people just popped on. We're doing some breakout rooms right now, so we will put you in a room. You might do them for like 7 minutes because of it taking a while to get in there. You know what I mean?
Yeah. I don't know why some people don't like stick in the rooms that they get put in. I don't know. It's very weird.
Yeah, so Sam can't get on. I don't know what to do.
Why can't she get on?
Her internet, for some reason, just Pendleton sucks. Their internet sucks so bad. I mean, so what's gonna happen is Martine's gonna do her slides if she can't get on. So
that sucks.
He's such a good guy.
I know.
I think it's going pretty good so far. How many minutes? How long has it been?
I didn't set them for a time.
Okay, let's set a timer for 3 more minutes.
Okay.
And then can you let them know that they have 3 more minutes?
Mm-hmm. Oh, maybe I did set them. I did set them for 5 minutes. They have like 1 minute left from the 5 minutes, but I think, increase it.
That's fine. That's fine.
Okay.
I wasn't sure if you already did or not. Hello, Lindsay.
Hello, I got kicked off when my phone rang.
Oh no.
Oh, weird.
That's okay. We're coming back in anyways. There's only 29 seconds left. So
I chose to do it from my house for a little bit today. And so I'm on my cell phone doing it. And when it rang, my work was calling in and it just disconnected me.
Mm.
So I look like that jerk that goes into the breakout rooms like, oh, I'm too good for this.
looks like everybody's starting to come back now. So that's good.
Thank you. Sorry.
No worries.
Welcome back, everybody.
All right, that was fun, I bet. So does anyone from their breakout groups want to share what they got out of that? Don't be shy. Oh, someone said they couldn't hear in the breakout room. Any
Yeah.
takers? Any
Hey,
takers?
Martine, how was your breakout room?
I was with Martine too.
Oh, perfect.
Martine, you're on mute.
Sorry. Yeah, so Damia was in that group. I took some notes. So we only got to 2 of the questions because we started discussing. But for the first question, what can you do to show support and acknowledge our diverse community? Stacy from Central Washington Family Medicine, mentioned that acknowledging the blessing of differences, and kind of hitting the video of how boring would it would be if everybody was the same. Imagine eating the same food every single day over and over again for lunch, dinner, and breakfast. That would get boring really quick. So just acknowledging, the differences that, there's in our communities and different cities, countries. For the second question, how do we teach our children the importance of diversity and celebrating our differences? Looking at holidays and seeing the differences in their meanings. We talked about Halloween, how there's Halloween here where kids dress up and go out trick-or-treating, whereas other cultures is more of a not necessarily Halloween, but it's a let's say Dia de los Muertos. It's a holiday for celebrating the dead. Kind of putting their favorite food out there for them and making their pictures and everything. And also Demia mentioned going to celebrations that they have either at schools. She mentioned public libraries, going and seeing all the different activities that they have. If there's an opportunity to taste food, tasting food from different cultures, and also seeing the different ways that they dress in their culture, whether that be Native Americans, to let's say somewhere in India where they dress differently than here, in Afghanistan and in Middle East. So there's looking at how people dress, and just teaching kids about the difference of the cultures that are out there. There's a lot, and just teaching them to respect them and be of acceptance to those cultures. So those are the only 2 questions that we were able to get through.
Did any of the other groups want to kind of discuss what they talked about in their group?
Diane, I can share what our group discussed. This is Carol.
Sure, that would be awesome.
Okay, so we had a few technology issues at the beginning in terms of hearing, but in my group was Laura, Jill, Heather, and Ed. And one of the things I thought they added to this conversation was the fact that our community panels, committees, leadership really needs to reflect the diversity of our community. That we need to be open and ask questions and continue to evaluate whether those decision makers actually reflect the needs and the diversity of our community, and that when an inequity is identified and recognized, that we make the changes necessary. And then Ed added at the end, we have to listen and evaluate our own mission and core values to ensure that they do incorporate diversity. Did I miss anything, you guys? Heather, Jill, Ed, Laura?
No, that sums it up really well.
Okay, all right, thank you.
Thank you for sharing, Carol, and everyone. All right, I guess we can move forward. So let's talk about unconscious bias and how it happens to everyone. You've been exposed to countless messages that, oh, sorry, 1 second, I can't see my screen here. Okay, you've been exposed to countless messages that define groups of people. Unconscious bias is a natural, universal method of cognitive processing. No one is exempt. For example, sorry guys, my screen is acting a little funny here. For example, society has presented you with representations of what it means to be masculine. These representations are repeated by media, teachers, and influencers. Once internalized, these stereotypes shape your thoughts, your actions, and allow you to meet a new person and instantly decide whether that person is masculine or not. Even if you don't believe in stereotypes, once you've been exposed to them, they're in your brain. And unfortunately, they can influence your decisions. Most people think of themselves as egalitarian or unprejudiced, but unconscious biases shape us all in particular ways. Next. Unconscious bias in healthcare settings. So this one is pretty wordy here, so let me know if I need to slow down. In medical school, doctors are taught that their personal backgrounds and the characteristics of their patients should be excluded from clinical decisions. But in reality, healthcare providers are just as susceptible to unconscious biases as the rest of us. Many non-medical factors influence medical decisions, including the patient's style of dress, their race, their ethnicity and gender, their insurance status, and the clinical setting. Evidence shows that medical conclusions can be based just as much on who a person is as on the symptoms they represent or they present. Unconscious biases can lead to false assumptions and negative outcomes. This is especially dangerous in the healthcare, where decisions can mean life or death. As more attention is paid to health disparities in the United States, there is an increasing evidence that unconscious biases leads to negative outcomes for minority groups in the healthcare settings. This in turn contributes to health disparities in which certain groups experiences inequities in the provision of and access to care. Next slide, please. Examples of unconscious biases leading to healthcare disparities. I'll talk about a few here. White male physicians are less likely to prescribe pain medication to Black patients than to white patients. Another one is doctors assume their Black or low-income patients are less intelligent, more likely to engage in risky behaviors, and less likely to adhere to medical advice. Pregnant women face discrimination from healthcare providers on the basis of their ethnicity and socioeconomic background. And last, women presenting with cardiac heart disease symptoms are significantly less likely than men to receive diagnosis, referral, and treatment due to misdiagnosis of stress or anxiety. So how do we overcome biases in the healthcare? First, we need to acknowledge that unconscious bias exists, and it's important first step to overcoming it. Nobody wants to believe that they're part of this problem. When you think about stereotyping, your first reaction is probably not me, but when you start to identify stereotypes that are prevalent in our culture, you'll realize how many you've been exposed to and how insidious they can be. Next slide, please. So let's cover a little bit about strategies to overcome some of these unconscious biases. First, we need to recognize stereotypical thinking. We need to replace biases and assumptions. We need to understand the individual or individuals. We need to explore a new perspective. We need to also increase opportunity for positive contact. So, overcoming, sorry. Okay, I want to finish reading this little part I have, this little blurb. 1 second, please. Overcoming unconscious bias isn't easy. It's a lifelong process that requires time and attention. The best way to start as an individual or an organization is with a proven framework, such as a cultural competency training and education program. We didn't develop our unconscious biases alone, and we can't banish it alone. Rather, our ideals must be reflected in our broader culture until the person-centered approach to communication is the new normal. Nowhere is this effort more important than in healthcare, where inequality and discrimination are a matter of life and death. Thank you.
Does anyone have any questions around unconscious bias or health disparities or health inequalities? Okay. So the next thing is we'll take a 5-minute break. This break, we weren't sure how long it was going to take, so we'll go ahead and give you guys a 5-minute break, and we will be back so at 9:40, and we will continue. All right, welcome back, everybody. So now that we have kind of gotten into this, we have a little poll we're going to do. This is just kind of a little fun little poll. So can you launch the poll, Stacy? Perfect. Can everybody see the poll there? It should have popped up right on your screen, and so then you can answer the questions as you are, and then we'll just kind of talk about them. It's just a little fun thing to, because everybody is different. Everybody likes different things, and it just goes to show that, there's diversity in everything that we do.
All right, responses are rolling in.
I know, I see. We'll give it another minute. Looks like we got a lot of people answering the questions.
Star Trek and Star Wars are neck and neck. I'm so interested who's going to win that one.
It's kind of funny that it's like almost even on some of these. All right, so it looks like we had a 60% of people like broccoli and 40% like carrots. It says eat out or cook in. We had 53% eat out and 47% to cook in. Scuba dive or go into outer space. We had 60% for scuba dive and 40% for outer space. Travel by train or by plane. We had 53% by train and 47% by plane. Drive or be driven. 60% likes to drive and 40% likes to be the passenger. A lot of people like the beach. I'd have to say that's my favorite too. So the beach was 80% and the mountains were 20%. And it's so hilarious because it's Star Trek and Star Wars that were 50-50.
That's awesome.
That's so funny. All right. Thank you for doing that. That was a fun little poll. So we'll go ahead and move on to cultural competency, and Martine's going to take this section.
Okay, we'll do a quick dive into cultural competency. Next slide. So in this slide, we're going to be looking at the definitions of both culture and cultural competence. Although they might sound the same, there's a difference to both. So culture refers to integrated patterns of human behavior that include the language, thoughts, actions, customs, beliefs, values, and institutions that unite a group of people. So that is the definition for culture. Cultural competence is the capability of effectively interacting with people from different cultures or belief systems from one's own. So that there's a difference from the definitions of culture and cultural competence. Next slide. Next, we're going to be watching a YouTube video that talks about health literacy and cultural competency.
There's an abundance of literature addressing costly healthcare disparities in the U.S. Disparities are influenced by a number of factors: culture, environment, and socioeconomic status, to name a few. Reducing healthcare disparities requires an understanding of these factors and how they influence patients and providers. Stephen Covey once said, We see the world not as it is, but as we are, or as we are conditioned to see it. Each culture has its own set of beliefs and values that affect how patients perceive everything around them, including their health care. Patient compliance and understanding are also influenced by socioeconomic and social factors. Patients don't leave their beliefs at the door when they visit their provider. Culture shapes our thoughts and behaviors. It influences the way patients respond to medical services and the way providers deliver those services. Healthcare providers today must be mindful of the social, cultural, and linguistic characteristics of each patient. This type of awareness is called cultural competence. What happens around us is processed within us and filtered through a cultural lens that helps us interpret every experience we encounter. The meaning we attach to what we see and hear is based upon who we are and what we believe. Ignoring cultural differences diminishes our ability to effectively communicate. This leads to communication gaps, confusion, frustration, and if this relationship suffers, so do health outcomes. But a culturally competent provider demonstrates a respect and understanding of cultural differences and considers how others might react to certain experiences. This helps to reduce healthcare disparities, improve health outcomes, and motivate patients to become equal partners within their own care team. And working as a team with your patients is the best strategy for accomplishing your goals. So you want better health outcomes and greater patient satisfaction? Respect and value cultural differences. Examine and evaluate your own cultural attitudes, and make appropriate adaptations to patient care. Understanding your patients will aid them in understanding their health. Cultural competency will promote compliance, mitigate healthcare disparities, improve health outcomes, and encourage patients to become your partner in their health.
Okay, so this slide, we're going to be looking at how does culture impact the care that is given to patients. Um, you know, our culture informs concepts of health, healing, where, some people might see that, medications are not the best option for them because, their beliefs, their culture is not embedded in them to go to the doctor and get medications. They might prefer to seek alternative treatments, whether that be natural treatments to other types of kind of not Western medicine. It also, informs how illness, disease, and their causes are perceived. Some cultures we'll see later on in a video that, you know, they believe that they got sick because they got cursed, or some in some cultures or some people believe that they might have gotten diabetes because they got a really big scare and that affected their blood sugar levels, and that's why they got diabetes. Also, our culture informs the behaviors of patients who are seeking healthcare. These might be some of those behaviors might be, how often are they going to see a provider? Are they going, once a year for their annual wellness visits, or are they just going, once they're really, really sick, and they might not be going to their primary care provider because they don't have one. They're going to the hospital because, to them, the hospital is where you go when you're sick. So we have to be aware, of those behaviors in the patients that we're providing treatment to and services to. The last bullet point here added to us toward healthcare providers. This is, maybe the patient can say, you know, the medication's not going to do anything, so why am I even going to take it? You know, that's a an attitude that can affect you know, our health. They might want to see me again so they can charge me more. That's another attitude, you know, or belief that they might have. They just want to see me over and over again and give me medications, and you know, nothing's really going to happen. So there's a lot more, and this is just, you know, a small dive into how, you know, culture informs our health, and also informs the providers on how to provide the appropriate care that the patients are wanting. Next slide. Culture impacts every healthcare encounter. Culture defines healthcare expectations, who provides treatment, what is considered a health problem, what type of treatment, where care is sought, how symptoms are expressed, how rights and protections are understood. Because healthcare is a cultural construct based in beliefs about the nature of disease and the human body, cultural issues are actually central in the delivery of health services. Next slide. Here, we are going to be going over what is a cultural competent professional. There are four bullet points. You know, it's not just those four bullet points that you would say, hey, you know, if you check off all four bullet points, you're a cultural competent professional. That's not the case. This is just to inform you guys and give you guys an idea of, okay, this is what, you know, it's involved in being a culturally competent professional. So the first bullet point here is a cultural competent professional is one who is actively in the process of becoming aware of his or her own assumptions about human behaviors, values, biases, preconceived notions, personal limitations, and so forth. So the key words on there are bolded. Actively in the process of becoming aware of his or her own assumptions. So we have to start with our own, you know, biases or what we think is culturally competent. The second, a culturally competent professional is one who actively attempts to understand the worldview of culturally diverse populations. In other words, what are the values, assumptions, practices, communication styles, group norm, group norms, biases, experiences, perceptives, and so on of culturally diverse clients, families, communities, and colleagues you may interact with. In this second bullet point, I really want to point out that this is in the words that are in bold, you know, actively attempts to understand the worldview of culturally diverse populations. Is not just because you work with one, you know, group of diverse people, you know, it makes you a you know, a professional in treating those, you know, people from that culture. You know, here we have to actively be attempting to understand and learn from, you know, different cultures or the same culture, just, you know, better becoming a better aware of what, you know, their preferences are. Next slide. The third bullet point here, a culturally competent professional is one who is in the process of actively developing and practicing appropriate, relevant, and sensitive strategies and skills in working with culturally diverse clients, families, communities, and colleagues. Again, in the process of actively developing and practicing. So it's not just being aware, but putting them into practice and learning from what you're putting into practice. Four, a culturally competent professional is one who advocates on behalf of the needs of clients, families, community, colleagues, etc. They take action in their workplace, community, and society to create a culture of respect and equity. Not everybody has the same access to healthcare. So, you know, for us as professionals, you know, you guys as providers, we have that obligation, you know, to advocate for those patients that are, you know, might be of, you know, don't have the necessary resources to get the services or the things that they need. So, you know, by us providing services to them, we have to be aware, that there are challenges that they might be facing. So we have to, advocate for them and take action, and creating a culture of respect and equity, not only in your practice, but also with, others that you work with. Thus, cultural competence is active, developmental, and an ongoing process, and is aspirational rather than achieved. Next slide. So Diane,
So I'll go ahead and we'll talk about some clear communications and foundations of cultural competent care. So we'll go to the next slide. So 20% of the people living in the United States speak a different language other than English in their home. The Hispanic population has grown by 43% in the US and has grown between the 2000 and 2020. Within our Greater Columbia region, we know that we have a very large Hispanic population. 17% of the foreign born population in the United States are classified as newly arrived, meaning they're arrived after 2005 or later. 1 out of 2 adult patients have a hard time understanding basic healthcare information. The average physician interrupts a patient within the first 20 seconds. So these are just some facts that we just want you to be aware of. Next slide, please. So the benefits of clear communication. So it's kind of like, as you can see, it starts with you improve the safety and appearance. You have the patient and physician satisfaction. It improves the office process and saves times and money, and it reduces malpractice risk. We often take for granted that the way we communicate with others, similarly to everything else we learn, and the way that we make interruptions, create assumptions, and form decisions based on cultural upbringing. Keep an open mind as you're communicating with your patients. Have at least some knowledge of that person's background and culture. Practice active listening and watch for those nonverbal communication. Next slide, please. So some of the influences that are cultural influences, so is at the center. So then you have all different kinds of things. You have the decision-making, the language and skill preference, the privacy, the other kinds of treatments. And so it is important to understand the way that people comprehend, communicate, and make decisions across different types of cross-cultural backgrounds. Although it may be difficult to interpret certain statements and behaviors, there must be a significant emphasis placed on the concept of its acceptance. Culture is the pattern of ideas and customs and behaviors shared by a particular people or society. These patterns identify members as part of a group and distinguish members of other groups. Culture may include all different kinds of subsets and characteristics. Next slide, please. So we're going to have a few of these slides, and you'll see. So on the one side is what the patient wished that the healthcare provider knew, and then on the other side is what the healthcare provider can do. So example, so this patient wants to tell they forgot their glasses at home and they're ashamed to admit it, and they don't read very well. they don't know what kind of questions to ask, and they're very hesitant. And when I leave the office, I often don't know what I should do next. So how do you think the healthcare provider can maybe help this patient feel comfortable? So it gives you some examples here, and it says to use different variety of instruction methods. Encourage questions and use the teach back method. And also use the motivational interviewing and those types of questions to help you understand if the patient actually understands what you're trying to teach them or tell them. Maybe repeat to them at the end of the conversation clearly what they need to do. And I know a lot of doctor's offices send home a printout with the information of what was discussed during the office visit. And I find that really helpful because then they could go home and have either their child or somebody in their family help them understand what happened at the doctor's office. Next slide, please. On this one, so this patient is thinking, I'm not able to make important decisions by myself. I am more comfortable with a female doctor. It is important for me to have a doctor to have a relationship with my doctor. I use botanical and home remedies, and I don't think to tell you. So on the other side, the way that we can have communication around this area is that they can confirm the decision making. You know, use the self-management tools as the navigators have, you know, taught is get the patient involved in making decisions on their healthcare as if they don't want to take medication, or there are other methods that they could use to be able to help them with what they're struggling with. And then it says office staff should be able to confirm preferences for during scheduling. So if that patient would rather be with a female doctor, then maybe the staff who are scheduling those appointments could ask, would you like to see this doctor or this doctor, depending on if that's available in that practice. Spend a few minutes building that rapport with that patient and getting to know them. And then one thing is you could ask if they use home remedies or healers as they instead of prescription medication. Next slide, please. So a lot of times there's a need for interpreter, you know, to have somebody do the interpretation. And if this is possible, it's really important to set that up and have that available for when the patient actually comes to the office for their visit. A lot of times people use a service to do these interpretation. So just some tips is to inform the interpreter as a specific patient needs. Hold a brief introductory discussion with the interpreter. Your name and the organization and the nature of the visit. If you're the doctor, talk to the patient, and the interpreter can interpret that to the patient. Allow enough time for the interpreter to explain what the physician is saying or the provider is saying. And so make sure there's enough time set for that session to allow that interpretation to happen. Avoid interrupting during the interpretation. So when the doctor tells, or the provider tells the patient, give the interpreter enough time to explain that to the patient without interrupting them. Next slide, please. So here's some more tips about interpretation. Speak in the first person. Talk like you're really just talking to the patient, and then the interpreter can explain what the doctor or the provider is saying. Speak in a normal voice. Don't talk too loud or too fast or go too slow. Just talk like you're talking to any other patient. Just allow the interpreter to be able to provide the information that the provider is explaining. Speak in short sentences. So don't make your explanations super long. And then avoid acronyms or medical jargons or technical terms, because a lot of times the patients will not understand those. Face and talk to the patient directly. That is the one thing that I think is really important for as a tip for interpreters, is that you're talking to the patient, and so make sure your body language and you're facing and talking to the patient. Be aware of the patient's body language to see if they're feeling uncomfortable, or if they're maybe not understanding what you're trying to explain to them. All right, so the next section we're going to talk about is cultural competence with the lesbian, gay, bisexual, and transgender and queer communities. So this, next slide. So this video, it's a little bit long, but it has a really great message. And I think it explains it far better than I could explain it. So we'll go ahead and go into this video.
To treat me, you have to know who I am. I identify as the Latina lesbian mother.
To treat me, you have to know who I am. I identify as a transgender man.
To treat me, you have to know who I am. I identify as a gay man. I was diagnosed with anal cancer, and when I'm dealing with something medical, it's extremely important that they know who I am. Every doctor I've been to, and there were 7, all of the nurses, all of the assistants, everyone treated me with respect.
It is as important to know somebody's sexual orientation, and even more than that, what their sexual scenario is, as it is to know if they're getting a good night's sleep, or if they have a good appetite, or if their bowel movements are normal. It's all part of basic bodily functions that are required for a maximum quality of life.
It's important to have an open and honest relationship with your patient. And so if you do not know what their sexual orientation is or how they identify, that patient is not going to feel safe telling you everything that they need to tell you for their proper medical care.
Knowing a patient's gender identity and sexual orientation helps a practitioner to care appropriately for that patient. We see a lot of patients come in who may not be comfortable disclosing that information, and routine testing or screening may be missed for that patient.
When I was about 15 years old, I remember going into the doctor's office, and my doctor was very warm and very welcoming. She was asking me all the questions that she's supposed to ask to an adolescent. And I remember telling her when she asked about my sexual activity if, if I use condoms or anything like that. And I said, no, I'm gay. And I just remember her face changed very much, and her warm tone of voice turned very harsh, and it seemed as though she was rushing me out as quickly as possible.
As a lesbian, unfortunately, when I've been involved with the healthcare system, it's usually hasn't been very welcoming. It's usually assumed that I'm heterosexual, and so the questions go along that line, asking me about the need for birth control. And then I fill out forms that ask me if I'm married, single, divorced, or widowed. And none of those boxes apply to me.
I think it's very important to know that what people write on forms does not represent necessarily their reality, and it does not take the place of a provider opening the door to ask questions.
And you need to ask those questions in an open and thoughtful and caring way.
Many times the patient or client want to talk about their sexual health, but fear that they would be discriminated against or stigmatized.
There are a lot of ways that a provider could ask me questions that would make it more likely for me to disclose the fact that I'm gay than not. So I'd rather them ask me if I am in a significant relationship, if I have a partner. And then I'd like them, when they talk about other issues, to not make an assumption that because I'm gay, I don't want to talk about having kids, or that I don't want to talk about relationship issues.
My partner and I and our children were on a family vacation, and my older daughter became sick. She got stomach pains, and we had to go to the local emergency room. And we get to the hospital, and they asked who was my daughter's parents, and I said, well, she has two moms. And they were like, well, she can't have two moms, only one of you can go in. My daughter was traumatized by that. We were traumatized by that.
It's not about sensitivity, it's about respect, it's about humanitarian response to a human being in general.
My partner was hospitalized recently, a very severe aortic aneurysm. When he was being moved from intensive care to a hospital bed, the nurse in charge would not let me accompany him. I asked if I would have been allowed to accompany him if I were part of his family, and she looked the other way.
What needs to happen when a patient is admitted to a hospital is that the care providers think about the fact that the patient might have different sexual orientation or different gender identity than the care provider.
Throughout my pregnancy, I was very much genderqueer, and I did tell them about my pronouns, which ones I preferred, that I preferred gender neutral or masculine pronouns. But the people who were dealing with me throughout my pregnancy, primarily my midwife and the nurses associated with them, were not responsive to my identity and didn't actually respect it. Certainly I felt that my healthcare has been impacted. I feel less genuinely listened to, and I feel like there's a huge discrepancy between the care I get versus other people who have gone to the same provider and report a very different experience.
You need to empathize with the patient you're talking to. Give them an understanding that you care to understand who they are. That's all you need to do. You don't have to use the right words. Just be open to being educated on what right words to use and care.
I just transitioned about 4 years ago to start living as a man. When I was diagnosed with breast cancer, I found that my breast surgeon was unable to call me even to give me my biopsy results. He did tell me very frankly and overtly that he had problems with my transgender status. And upon meeting me and learning of my transgender status, he decided that his first impulse was to refer me to psychiatry.
I used to work at a health center that did a lot of care for transgender patients, and there was a lot of discrimination towards those patients. There was a discomfort in talking to them. I myself had some discomfort because I didn't have much training in how to work with transgender patients.
The other day, a patient came into the office and his insurance cards identified him as Adam, although he signed the register as Emily. After being called multiple times by his birth name, he left the office.
I do think the LGBT community has special needs. I think the LGBT community has a specific special need, which is to be treated the way non-LGBT people have been treated forever, which is to be asked about their sexuality, to be asked about their quality of life, what their home situation is, what their work situation is, what their friend situation is, without the person asking the questions being afraid of what the answers might be.
Recognizing the differences of human beings and being able to address the issues and not using one ruler to measure someone else's existence or purpose in life.
My greatest hope for LGBT patients in the healthcare system is that when they go for treatment, whoever they're going to see accepts them for who they are.
And having the people that we choose to be our families be accepted, to have them be a part of the healing process.
And the healthcare system can take care of us just like anybody else so that we can keep ourselves well and get the information that we need.
To treat me, you have to know who I am. I identify as a lesbian.
To treat me, you have to know who I am. I identify as a genderqueer, biracial, Latino parent.
To treat me, you have to know who I am, and I identify as a lesbian.
Our lives depend on your capacity to care.
I love that video because it talks about, to treat me, you have to know who I am. And it's such a strong line statement that I think, it can apply to everybody, but especially to our LGBT community. Next slide, please. So some of the disparities that are within the LGBT populations, there are, they delay care. They have suicidal ideations. Their alcohol use is a little bit higher, and the smoking of the cigarettes is higher in there as well. Next slide, please. So back to our little, what does the patient want you to know, and what can you do as a provider? So on this side, it says that they come in with a little bit of extra anxiety. They're verbally and physically abused sometimes. Sometimes they're rejected by their own families due to their sexual or gender identity. They're discriminated against within the healthcare setting. And at times they've experienced harshness and it has with rough blood draws or rude orders. And it's so, you think that it wouldn't happen, but from the research that I have done when I was putting together this PowerPoint, I was so surprised on how how much there is in how this is still, the stigma around this is just still played such a role in healthcare right now. What the provider can do is have a warmth, a little warmth can make all the difference. Be judgment free. This is their life. This is their choices, and you are there to help them and provide care for them, and not to be judgmental or discriminate against them. Have policies about non-discrimination of sexual and gender identity displayed in common areas, so that your staff are aware as well, not just the provider, that the staff and the MAs and all the people working at this place are non-judgmental or discriminate against the LGBTQ communities. Listen to how the patient refers to themselves, their pronouns, and then use that same language that they use. And if you're unsure, ask questions, and ask questions in a warmth and kind way, and try not to judge them. Next slide, please. So this is another one. So let's say that hetero, I cannot say that word for some reason. Does anybody know how to say that word?
Heteronormative.
Thank you, Sam.
You're welcome.
Assumption and the attitudes for our future care seeking. Discrimination in healthcare may delay and defer treatment. A lot of times the patients, they in these communities wait too long to seek healthcare because they are fear of being judged. So anticipate that. So for the provider, anticipate that all patients are not heterosexual. Use the word partner instead of spouse or boyfriend, girlfriend. Replace the marital status as a relationship status instead of asking if they're married or what's their boyfriend or spouse. Use the word partner and use the word relationship. These are some of the ways that you can avoid some of the mistreatment or mistrust that they may have. Next slide, please. So on this one, the transgender patients have specific health concerns. So 19% of them have refused treatment. They may experience more trauma during a removal of clothing or a pelvic examination. And this could be from trauma or from something in their past that, brings back a trauma that they've had in the past. Not all transgender people want to have hormones or surgery to align to confirm their gender. As a provider, you can always prefer use their pronouns and their preferred name. Ask them what they would like to be, what they would like to be called if it's different than what's on the paperwork. And the topic of a body modification activity should be approached with care. Do not let curiosity lead to examine body parts that are not involved in the medical issue at hand. And then Carol put in the chat that I've noticed that in our region, it doesn't refer to a person's pronouns like on the west side of the state. Carol, did you want to make a comment about that?
Um, kind of. I mean, I don't know what the right thing is. I don't want to be out of sync. I want to be sensitive. But I just noticed that, you know, whenever I'm logging into a meeting on the west side, it's very, very common. And I didn't know, you know, what what our region feels about that, especially as we're talking about this, Diane. So just wanted to kind of throw it out there.
Yeah, I also have noticed that as well. Does anybody on the line want to comment about that?
This is Kendra. I haven't noticed it as much happening in the Tri-Cities. I moved from Portland, so similar to, I guess you refer to that as the West Side, where it was much more common to see that. But at Catholic Charities, we did talk internally, and now staff can opt in to use pronouns in their email if they want to. So that's something that we've done over here.
Oh, thanks, Kendra. I appreciate that.
All right, so the next slide, we're going to take a break. So let's take a break and let's be back at 10:32. So about 5-minute break. Is that long enough, or do you guys need a longer one? Okay. Okay, so if you go to the next slide. So poor Sam, she is having technical difficulties today. So Martine is going to step in and kind of help her out here. And I will also, but she is on the phone, but she just can't see the slides. So we'll go ahead and proceed.
Okay, so for this part of the presentation, we're going to be talking about cultural competence, refugees, and immigrants. Just with what we have recently seen, in Afghanistan, where, there was thousands of people that are now refugees here in the United States. I know that there's some that are in the Tri-Cities area as well. We have to be aware of their culture and what their preferences are. So healthcare reform, healthcare for refugees and immigrants. Refugees and immigrants may not be familiar with the U.S. Healthcare system. Even for those of us that have lived here, for many years, the healthcare system can sometimes be confusing. They send you to one provider, then send you to another one, then they send you to go see a specialist, and they do a lot of things. For us, that can be confusing. It can be sometimes just, it's hard to navigate the healthcare system. Now, imagine them that are brand new, they might not speak English, they're not familiar with the healthcare system. Imagine how they feel. They can also experience illness related to life changes. The diets are very different from the diets we have here in the United States to the others in other countries. So there might be the cause of or illness with the changes in that they've had, and it can be very traumatic for some. That can cause trauma, and also it's just big life changes that they have gone through. Also, they practice spiritual and botanic healing or treatments before seeking U.S. medical advice. Again, I mentioned this earlier during my piece of the presentation, where they might have a preference to not take Western medications, pills or go through treatments, because to them, that's just something that maybe they have never done, they're not familiar with, they might not trust, the healthcare system, so they might be inclined towards more, spiritual and botanic healing rather than seeking Western medicine. Next slide.
Martine, can I add to that, please?
Yes.
This is
Yes,
Sam, and thank you for taking my slide. I just wanted to also add, it really has a lot of factors around the refugee, especially in the camp conditions and their geographic region, and they face a wide variety of acute and chronic issues that they might have barriers to healthcare for, especially around post-traumatic stress disorder and depression. Um, and those having those diagnostic and treatments challenges in being able to have that access has been one of the larger issues. Many of them have been fortunate enough to get short-term insurance or healthcare coverage. So we are thankful for that. But long term, still looks like a barrier for these individuals. But again, just thinking about what they're exposed to, those infectious diseases such as tuberculosis and intestinal parasites, and being able to assess those patients based upon where they're coming from, where they're going, those campsite, and what kind of conditions that they're living in. Thank you.
We'll watch another video that's really informative.
We were kids who were placed in the system and we were expected to function like every other normal kid in the United States. But in reality, we were normal kids. We didn't have any physical deformity or anything visible, but we had scars that were invisible. A lot of them did not make it. Some of them died because of they joined a gang. Some didn't make it through depression. I think, overcome it all, like when I look, I see, like a kid, we had the war, kids are, to be seen but not to be heard from. So nobody was comforting us or, there to attend your emotion and say, you went through war, you watch people blown into parts, we lost our belonging, our home, our whole identity. But this is why nobody ever said that. So it just left us alone. And then we came here, and here in the United States, people are like, oh, here's your physiology needs in your home and everything. But you're forced so much to just be your own self in a short period of time, and all you hear is, why are you not assimilating, why are you not becoming? But that time is when I felt like when we were our worst self, it's when you, for the first time, we were no longer, as a kid, I was no longer watching after my sibling, I was no longer worried about water or food, or if my mother would get to a medical facility every time she had a miscarriage. So after all that, responsibility was no longer on my shoulders. I was forced to face me. My highest point will be who I am today. Yeah. Now that I am an interpreter myself, working in Maine, I find that a lot of people would put me under the category of an expert. And I used to say that, what qualifies me to be an expert? I'm just a Somali person. I learned what Somalia is and how their government was working, whatever. Like any other American person, I Google a lot. Even though we have one culture, one language, whatever, we also have different cultures individually. Every household have their own little culture, that the way they raise their kids, the way they go about the Islamic religion is different than the next door. So not to assume that we all dress alike, eat alike, talk alike. It's not the case,
This is Najma, a 20-year-old woman from Somalia. Last year, Najma and her husband were set to be resettled by the United Nations to Lewiston, Maine. 2 weeks before their departure, Najma's husband died of a respiratory infection he contracted in the refugee camp. A month later, now in Lewiston, Najma discovered she was pregnant. Najma's neighbor urged her to make an appointment to see a doctor. She said it was very important for the health of Najma and her baby. In Somalia, people only see a doctor if they feel sick, but trusting her new friend, Najma made an appointment. The receptionist told her to come at 2 o'clock on Tuesday. She had errands to run till 5, but in Somalia, patients wait to be seen, sometimes in the order they arrive, sometimes at the discretion of the doctor, sometimes for hours, so coming later would just mean someone else would get the chance to see the doctor first. The errands took a little longer than expected, so Najma arrived at 5:30 and was flustered to find the clinic had closed. When Najma called the next day, the receptionist said that they closed at 4, as always, and that Najma needed to show up the next day at 10 a.m. or else there'd be no time for her for a month. This wasn't anything like the system she was used to. Najma felt terrible being spoken to like this. She hadn't meant to convey any disrespect to the receptionist, and she was frustrated because she had no idea why she, a healthy woman, was going to the hospital anyway. The next morning, Najma took a little longer than normal getting out of bed. She'd been sleepy in the mornings lately, but she was only 15 minutes late, so she figured she was close enough. The receptionist did not agree. She rebuked Najma for her selfishness and lack of respect for others. She then handed Najma a clipboard of forms to fill out and sign. None of this made any sense. In Somalia, there are no set appointment times. Doctors take as long as they need with each patient and then call the next in line. There aren't any forms to sign because records are seldom kept. Najma wondered if the forms meant she was in trouble. She could speak and read simple English, and the forms had many questions about her family and her past. Some questions were very personal. Were these questions for the police? Would they be used against her? She wished her husband were here to handle these things. She felt like there was no one to help her. She did as she was told and filled out the forms, hoping not to get into any more trouble. Najma's name was called by a cheerful woman who introduced herself as a nurse. She didn't know that word. The nurse did things Najma expected the doctor to do, taking her blood pressure and pulse. She asked more personal questions. Then she left, saying the doctor would be along. Najma waited 10 minutes for the doctor. Why had the receptionist been so angry about Najma not arriving on time if she was just going to be kept waiting? Why not just come get her when they were ready? In Somalia, the powerful often kept subordinates waiting. She guessed that's what was happening here. The doctor finally came. Najma was relieved. The doctor looked at the computer and then examined her a little. She said Najma showed signs of anemia. She told her she was ordering a blood draw for a full CBC and a prenatal panel. Najma didn't understand any of that, except bloodletting, which was a treatment in Somalia sometimes. She didn't feel sick, but the doctor said she had something wrong with her. She was embarrassed and scared to ask the wrong questions, so she didn't ask what it was. The doctor left, and a lab tech came and took some of her blood. After the appointment, Najma was confused about who her doctor was. In Somalia, you only saw the doctor, but there were so many people here, and the one she spent the most time with was the nurse. Was the nurse the doctor here? Najma got a call 2 days later from the nurse, saying they wanted to test her hemoglobin and ferritin levels. The nurse also said they would send her a card telling her what foods to eat. Najma got the card titled Iron-Rich Foods. It was full of strange foods she didn't eat and didn't know how to cook. She knew some foods were used as medicine, but she didn't feel sick, and she ate good food anyway, so she threw it away. Somali doctors typically call patients to schedule follow-ups, so when the doctor never called, she decided to take it as a blessing and be done with it. Nothing helpful had come from her visit, and it had been very unpleasant. A few weeks later, Najma's neighbor got to asking how the appointment had gone. She was dismayed to hear what a catastrophe it had been. She took it upon herself to phone the office and schedule another appointment for Najma. In the interim, the entire healthcare team at Najma's clinic had attended cultural competency seminars conducted by Maine Intercultural Communication Consultants, and they'd learn how to better treat patients like Najma by examining their own culture, learning about Somali culture, and discovering the many unexpected ways culture shapes us all. They also learned cultural bridging techniques to communicate their messages more effectively, as you'll see in a moment. This time, the receptionist gave Najma a reminder call for her appointment, and she explained that the doctor only had a short time with each patient before the next one. Each patient had to be there on time or they'd miss their spot, like you'll miss the sunset if you aren't there to see it. This was different for Najma, but it made sense. She was always on time to appointments after that. When she got to the clinic, the receptionist told Najma why she had to fill out those forms. They were for records, so the office could remember every patient over time. Sometimes doctors could look back and solve illnesses that a doctor without records couldn't solve. And if Najma got a new doctor, he or she would know all about her. She told Najma the information was confidential, which meant it could never be shared without her permission or used against her. The nurse explained her role to Najma. She was part of a big team that worked to keep lots of patients healthy. She explained why patients sometimes have to wait for the doctor. She told her that some patients need extra care, or sometimes emergencies happen, but by being ready in the room, Najma could see the doctor as soon as possible. The doctor came in, and this time she explained anemia, and how even though Najma didn't feel sick now, it could make her very sick later. It was hard for Najma to understand being sick without feeling sick, or the idea of curing an illness in the future. But the doctor explained how they could see the causes of sickness before they were felt, and before they were dangerous. The doctor said she'd like to do more blood tests and explained what could be learned from those tests. She asked Najma if that was okay. Najma's doctor provided her with another list of iron-rich foods, but this list was developed in partnership with members of the local Somali community. It featured foods that Somalis ate and could buy locally, and some recipes too. Najma recognized some of the foods as being fed to pregnant women in Somalia, and now she understood why they were good for her. Najma asked the doctor if she could be a community partner too, so she could help patients like herself understand how to get the care they needed. The doctor said that would be wonderful. Remember, no one knows everything about every culture, let alone every individual within every culture. But by increasing your cultural competency, mistakes can become opportunities for learning and authentic human connection. Working cultural competency into all levels of your practice, gaining insight into your own culture as well as others, and using the cultural bridging techniques like the ones discussed here will allow you to serve all patients with the best, most equitable healthcare possible.
perfect. What a great video that shows, you know, the difference it makes in just taking, you know, a little bit more time. We know that, you know, all of you guys as providers, especially primary care providers, are very busy in you know, throughout your day and have limited time. But just, you know, taking time, a little bit of time to explain, you know, the importance, you know, the huge difference in the health of your patient. So here we're gonna look at again, you know, here's what we wish our healthcare team knew, and here's what your team can do. So here's on the left hand side, my expectations do not align with U.S. managed care, and we saw that in the previous video that you know it just didn't make sense to her, you know, the way that the healthcare system is set up here compared to Somalia, where she came from. I'm bewildered by requirements to visit multiple doctors. Again, you know, that's a big difference that some people might not understand. And the last one here, I wonder why I have diagnostic testing before a prescription is written. You know, many people from you know different countries that come here as refugees or immigrants might not understand that, hey, you know, we really need to figure out what's really going on with you before we give you any type of treatment, where you know maybe where they came from, a treatment was provided first without really knowing, you know, what was the main issue as to why they were feeling ill or had, you know, that condition. On the right hand side, we have here's what your team can do. You know, the first one is you can inform your patients that they may need follow up care, and explaining to them, you know, why it's important to keep your scheduled appointments. Maybe, you know, this is to monitor the condition and make adjustments if the treatments are not working. You know, that's one way of explaining to your patients. You know, one visit might not be enough because we need to, you know, constantly monitor your blood sugar levels, your anemia, your you know, depression scores to see if you're improving or if you need to adjust or, you know, give you different options for medications or treatments that are available. The next one is explain why a patient may need to be seen by another doctor. You know, here there's an opportunity for teaching, you know, immigrants and refugees that, you know, you as a primary care provider or as a behavioral health provider, substance use provider, um, it might not you might not be the appropriate person to treat their condition because you're not as, you know, you're not a specialist. A specialist, you know, they specialize in those specific conditions, can provide better treatment, thus, you know, having better health outcomes for that specific patient. um, and the last one here is emphasize the importance of medication adherence. They might not be familiar with, you know, taking medications on a scheduled basis. That, you know, for them maybe if I get it, you know, I'll take it, maybe I'll take it here and there, or you know, it can be things such as, you know, I don't have a lot of money that I can keep buying this medication, so I'm gonna, you know, try to stretch it out and see how long it can last. So explaining to them, hey, you know, we really need to keep on schedule and take your medications, because if not, you know, there can be repercussions. You know, you might develop other conditions that will require you to see more doctors, you know, spend more time in a clinic or, you know, even a hospital. And it can also, you know, by developing other conditions, you might need to be taking extra medications, you know, that you're going to have to be taking on a scheduled basis as well. Next slide. Common office expectations. Here are the first one is on the left hand side again. Here's what we wish our healthcare team knew, and maybe, you know, like Diane mentioned earlier, these are things that are running through our mind as we're in the provider's office, thinking, man, I really wish we knew this, but they don't say it. So the first bullet we have here is I have different expectations about time. Again, going back to that video, you know, where that lady from Somalia, you know, to her, she would be seen either way if she arrived early or late, which was not the case. You know, I prefer to have someone of the same gender. This is a very big deal for some cultures. that they can only be treated by, you know, a man or a female provider, depending on their gender. And the last one here is, I'm going to bring friends or family. They want to help make decisions. You know, that's a very important thing to do, to provide decisions. On the right hand side, here's what your team can do. Upon arrival, inform patient about wait time. You know, that's very important, as they might not be familiar with how appointments work here in the healthcare system in the United States. You know, there's limited time where you can be seen, and you need to be there early and on time, so that, you know, they can have everything ready for the provider. Accommodate a doctor or interpreter of same gender. Um, you know, that's important. And more on the interpreter side, to make sure that, you know, they're translating at a language and at a level that the patient can understand. Because if they're just repeating what the doctor, you know, is saying, they might not be able to understand it, because, you know, they're not familiar with the healthcare system, or the lingo that's being used, or, you know, they just might not be familiar with the condition at all. So to them, it's just something, well, what's diabetes? You know, well, what's in my blood? So, you know, we need to be able to make sure that, you know, patients are providing or receiving translation services that, you know, at a level and at a language that they can understand. The last one, confirm decision makers at each visit. You know, making sure that you guys as provider provide, you know, options uh, for the decisions that are being made about the patient's health, and involving them or a family member, somebody that has, you know, the authority to make decisions for that person. You know, that has been shown to have great outcomes in patients' health. You know, the patient feels empowered because the provider is taking their opinions into consideration. You know, for practice transformation, the work that we're doing with our contracted providers, you guys know that one of the milestones is, you know, providing shared decision making tools, so that patients, you know, can have a voice and have an option as to, you know, what treatments is best, that they see as best for them. Because maybe what the provider is, you know, telling the patient, hey, you know, I think that this treatment or this medication, or, you know, referring you here might be the best option for you. When, you know, the patient might say, well, if you refer me here, it's going to be too far for me, that I won't be able to make it. But they don't know that. Or, you know, maybe this medication is going to make me gain weight, which I don't want. Is there another option? So providing those options to your patients is very important. Again, it makes them feel empowered, and, you know, they're more involved in their care when it comes to self-management as well. You know, when they're at home, most of the care that the patient receives is at home. You know, they're not at the provider's office 24/7. They're there for maybe, you know, half hour or less, depending on the appointment type. And then they have to do a lot of self-management at home. So providing, you know, those options where the patient feels empowered, and, you know, they'll be more involved and have better outcomes. Next slide. How to address confidentiality. Here's what we wish our healthcare team knew. I have different experiences in refugee camps. You know, we saw that in Somalia, that there's in the video from the lady from Somalia, they had been through, you know, through refugee camps where they, you know, unfortunately her husband ended up passing away because of something that he, you know, he got while they were there. My experiences have caused me to be suspicious. They might not have the best experiences, you know, in the different, if they've been, you know, going from refugee camp to refugee camp, or if they've been traveling to where they are now. You know, their experience with all that information, you know, something that it's, you know, can be sacred to them to not share, and now they have to share it, is like, why are you asking me this? You know, you guys have to be aware of the suspicious. The last one, I fear my health information will be released to the community. We saw that in the video as well, that she was hesitant to share that information because she didn't know where that information was going to end up. What your team can do is explain confidentiality, explain how it works, explain that there are rules that the organization and the site is held by HIPAA, 42 CFR Part 2, that it's for them, they'll get in trouble if they share that information with anybody that's not that doesn't need to see that information, and make them feel that it's information that's really important to us, and it's information that we're going to keep protected from others, from others being able to see it. Ensure that staff adhere to your policies. Annual trainings on policies around HIPAA, 42 CFR, and then having those as part of onboarding trainings for new employees as well, making sure that they understand, hey, we really need to abide by HIPAA and 42 CFR, and making sure that we're not sharing any patient information with people that don't need to see that information. Make HIPAA forms easy to understand in preferred languages. We saw that in the video as well, that the paperwork that she was signing, it just had very confusing language on there for her level of understanding. So making sure, again, providing your patients materials that are in any language at a level that they understand is very important, so that they feel comfortable with the care that they will receive, or that they are receiving, and also that they feel comfortable being there because they know that, hey, this site really understands me and provides information in a language and at a level that makes me feel comfortable. Next slide. Cultural competence with seniors and people with disabilities. I will be taking the slides on again for Sam. Next slide. Another video on overcoming cultural and societal barriers that impact those with disabilities.
Many communities in the majority world, because of culture, don't know how to respond to disability. The tendency is to respond culturally. If you take Africa, for example, African traditional religion labels anything that is unusual as a curse. And so, you have a child with clubfoot or hydrocephalus or whatever disability, someone bewitched you. There's something that you did in your family that has brought this upon you. Or you killed someone, and the spirit of the person you killed has come back, to punish you.
I think over time, it's a slow change to change culture and to be patient with people and to understand that everyone comes in with their preconceived notions. I come with mine and they come with theirs, and depending on what culture we've been brought up in, we're gonna come in with different notions of what is normal, what is good. I mean, even think about how women are viewed in certain cultures. Different weights are preferred depending on the culture that you're in. So in the culture of disability, people are going to think they're not enough because that's what people have told them most of their lives.
I came to know that it is more of an attitudinal problem in India. Like in Hinduism, the law of karma, and in Christianity is the parents' sin that has been visited upon the children. And so when we say that it is an attitude problem, we thought that our God is a specialist to change our attitude and our heart. And so we said that, yes, I mean, that for you it's a problem, but for us it is an opportunity where we can work. And so through puppet shows, we try to bring the awareness of change your attitude. And so attitude, if the attitude is right, it is both for the disabled person also and for the people who with the abled body. If a person is disabled but having a right attitude, a positive attitude, he can enjoy his abundant life, which we have in Jesus Christ. But if a person with an abled body but having a wrong or negative attitude, he still cannot enjoy that life. So for us, when we do this puppet show, we take it, this message, we want to pass on this attitude to all the people rather than, body and all those. So attitude matters a lot.
The traditional mindset of mental illness, for example, I don't know in other parts of the world, but in Liberia, is that it's traceable to witchcraft or some voodoo. So somebody with a mental condition comes to the facility, he feels, the person, the security or the cleaner feels that if he comes in contact with the person, he will contact the condition. But helping them to understand that having mental illness is just like having malaria, but just that the person is sick in the mind. So he has right to come for treatment, to be assessed, and to have treatment in there. So to create a kind of environment that is stigma-free, that is acceptance. And that's also the same with the local church.
One of the things we should always do is assume ability. Instead of assume disability, assume ability until they tell us otherwise. So one mistake we make is that people are not able. I've actually had people on planes try to cut my meat for me because I just happen to hold my knife with my elbow. It's just the way I work. It's not a problem, it's just how it is. So assume ability unless the person is asking, or if you want to help, ask them if they need help.
In my country, the places are not very friendly for people who maybe travel with wheelchairs. It's still very, very backward in terms of rights for them, for the disabled, rights for people with different abilities. And so I would hope that there is a secular group that's fighting, but I don't find the church there. So I hope that the church would take up the fight and be the center to fight for the rights and to fight for, just inclusion in schools, integration, and issues that people who are differently able face.
Okay, so here's a small chart with some of the things that for those of you that work with seniors or people with disabilities or have worked with them in the past, some common things that they have, they have physical impairment. They might have disease, multiple diseases with multiple medications. There's the caregiver burnout. That's a very big piece to focus on as well, because the caregivers are the ones dealing with especially for those that are more severely ill, that they need more assistance. Um, the caregivers can burn out, and thus not provide the necessary help that is needed for those specific individuals. Cognitive impairment, mental health, visual impairment, and hearing impairment. So those are some of the things with that seniors or people with disabilities encounter in their everyday lives. Disease and multiple medications. And Sam put in a chat message on here. He says many times the caregiver forgoes their own health, and that is very true. They feel that they can get sick because they need to be taking care of this person. So sometimes they ignore their own physical and mental health, and that really affects them as well. Thank you, Sam, for that comment. Again, on the left-hand side for this slide, here's what we wish our healthcare team knew. Neurocognitive processing ability impaired. There's pain, stroke, hypertension, diabetes, UTI, pneumonia. Meds can affect cognition, pain medication, antidepressants. And if, for those that are taking multiple medications, there can be medication interactions, whether and some of those can be negative interactions, making the patient need to go to the hospital, emergency services, or, just they might need to have some medication management so that they're not, these types of interactions don't happen if they're taking multiple medications. What your team can do is aware, slow down, speak clearly, use plain language, recommend sensitive assistive listening devices. For senior people and those with disabilities, talking fast, like you're talking to somebody that's not impaired or is not a senior, it might be normal. But if for those people, you don't know if they're hard of hearing, so you have to slow down, pronunciate your words. It doesn't necessarily mean that you have to talk louder or yell to them. It's just slowing down so that they can better understand you. Maybe they're able to listen in better and read your lips, that it makes sense for them for what you are talking. And again, using plain language. When they go to the doctor and they might say, oh, hey, your A1C is this. Some might not know what an A1C is, so you have to explain to them, this is your blood sugar level that you have in your body that's making you sick, and this is what can happen if we don't get this condition under control. So not using acronyms. I believe Damia, you mentioned that earlier in the presentation, and just using plain language that they can understand. Again, going back to that, to the using language at a level that they can understand. Whether that be seniors or people with disabilities, and also for their caregivers, because if they have a caregiver, they might not be familiar with some of the terminology that is used in the medical setting. And then also obtain a thorough health history. We saw that in the video with the lady from Somalia, where they explained to her, why it is important to obtain their family history, because, or even past health history from that specific individual, because that can help providers better understand, okay, this is what's going on because in the past you've had this, so it might be still causing issues at this time, so they're able to better create a care plan for those specific individuals. Next slide. Caregiver burnout/burnout. Here's what we wish our healthcare team knew. About 12% of active caregivers may have their own limitations. 16% of working seniors are also caregivers. And caregivers report more stress, higher likelihood of depression. Like Sam mentioned, they tend to forego their own physical and mental health because they're worried about those specific individuals that they're taking care of. So they really want to help them and be better, but that's not going to happen if the caregiver is not paying attention to their own health. One of the things that can happen is that they can suffer depression, and that can snowball into other conditions if it's not addressed. Here's what your team can do. Ask about caregiver responsibilities and stress levels. What are some of the things that you as a caregiver do for this specific person? And ask them, well, do some of those things cause you stress? And if so, what's your level of stress for when you do those specific things? Or when you go home, how do you feel? When you're not taking care of that specific individual. Offer caregiver support services. If they're suffering from depression, do a PHQ-2 or a PHQ-9 for that specific provider, and try to get a baseline of, I say, okay, well, you're not depressed, but here are some things that you can do at home for self-management when you are feeling a little depressed, or you feel that there's too many things going on. Take a deep breath, do some relaxation techniques. Here's a small handout on how you can do those. And just let them know that, hey, you might be able to see a provider as well, so that your health is good and well, so that you can perform your tasks as caregivers fully and are feeling well to perform those tasks. Next slide. Cognitive impairment and mental health. here's what we wish our healthcare team knew. Patients with dementia may need a caregiver. Other adults suffer more losses. Older adults suffer more losses, may be less willing to discuss feelings, high suicide rates for 65 and older individuals. Here's what your team can do. Communicate with patient and caregiver. Tell them about the importance of mental health. Even in, for senior people, they do feel depressed. They might have seen a lot through their lifetime that, they have a lot of trauma. And that trauma is now coming forward and affecting, this individual more than it did in the past. And also, the caregiver making sure that they're aware of those issues. Assess for depression, dementia, and cognitive ability. I know, that some of those things might be, they might take some time because, some of the assessments can be long. They ask a lot of questions, but it's important to know, if your patient is suffering from dementia or is starting to feel the effects of dementia, making sure that you as provider are aware of that so that, it can be addressed right away and come up with a plan for future care for that specific individual. Next slide. Here's just some graphics of visual impairments that people suffer. Molecular macular degeneration. That's how people suffering from that specific condition see. So the problems are reading, depth perception, contrast, glare, loss of independence. Because they have a really hard time seeing. Diabetic retinopathy. That's how they see really botched. So it's just to kind of get a glimpse of people with these conditions, how they see and how it affects them. Solutions, so decrease glare, bright and direct lights, bright contrasting colors, large non-serif fronts. The cataract, that's how people see, and the glaucoma, that's how people with those that specific condition are able to see. So there's different types of visual impairment. So we have to be aware of if they are suffering from any of these, again, to treat that individual with appropriate care. Hearing impairment. Here's what we wish our healthcare team knew. I cannot say that word, but I'll try to say it. Proboscis, gradual bilateral high frequency hearing loss. Consonant sounds are high frequency, word distinction difficult, speaking louder does not help. Here's what your team can do. Face patient at all times, speak slowly and enunciate clearly, do not use contractions. Rephrase if necessary, do not cover your mouth, reduce background noise, air conditioner, TV, hallway noise, etc. Audible solutions offer listening devices so that they're able to hear better. Next slide. Physical impairment, pain, or here's what we wish our healthcare team knew. Pain and reduced mobility is common due to osteoarthritis, changes in feet ligaments and cushioning, osteoporosis, and stroke. Here's what your team can do. Keep hallways clear, lower exam tables, add grab bars / railings to hallways, to stairways or ramps. For those that are able to still walk on ramps, having something to hold on to is really important. Use exam room nearest to the waiting area, so they don't have to travel long distances, whether that be with their walkers, crutches, a wheelchair, just so that it is just an easy access for them to get the services. Offer assistance, transfers, opening sample bottles, etc. recommend in-home accessibility assessments. And for those of us that are not physically impaired, those might seem like simple things that are like, oh, well, there's something in the hallway, I can just go around it. Imagine being on a wheelchair and say that specific thing is taking up half of the hallway. It's that person in the wheelchair is not going to get through because the wheelchair doesn't fit. So we need to just be aware of even the small little things that you can say, well, that might not make a difference. It will make a difference for those that are physically impaired. So just keeping that in mind, and also training your staff on how to be uh, better equipped to help people with physical impairments. Next slide. So that was it for
training.
Go
Martina,
ahead,
I'll go ahead and kind of wrap it up. So I really appreciate you guys being here with us today, and thank you, Martine, for pinch hitting for Sam. Sam, did you want to have any closing comments?
I actually have a question. I wanted to know if anyone in the audience would like to share what type of trainings they have within their organizations around DEI, please.
I know that Greater Columbia is starting their journey with diversity, equity, and inclusion. And Damia is our JEDI specialist, which stands for Justice, Equity, Diversity, and Inclusion. But yes, we would love to know if are there any other organizations, if they've started this path through with their organization and how they are doing that within their organization. Mark Lowe says they do an initial and annual training for all staff, and they have for many years. Perfect.
This is Berta with Yukon Valley Memorial. So we do education and orientation for new hires. We used to do a physician-specific training that was actually offered from the Mass General. They have an Institute of Diversity and Inclusion that's pretty good. So they offer, it's a training that was developed by physicians for physicians that gives kind of real world examples. So we've offered that in the past. I know we're trying to do more on some of the stuff that's best practice, like looking at your analytics of who you hire and who gets interviewed or who's applying compared to who we hire, and then the retention piece around how are we retaining and making people diversity feel included. We're also offering it's a intercultural development inventory assessment that several leaders in some groups have taken. It's from the company is Intercultural Development Inventory. I think that's their name. But it's evidence-based and it's an individual assessment that is taken. I highly recommend it. You take it and then it gives you kind of a framework of where you're at, where you've landed within the continuum, and it's a 5-step continuum. And then it gives you an individualized plan that you as an individual can look at and implement to grow within the continuum if you so choose to. And it's individual, but you can also do groups. So I've done I'm qualified in that tool, and I've done groups such as the Health Equity Guiding Team. We want to deploy it to the executive level group. I would like the board to take it as well. And then we've also done our human resource department. As you would know, obviously you want that team to be really just adept to identifying whether it be cultural conflicts and not really minimizing if somebody's complaining about a specific issue that's related to culture or bias, that they're not like overlooking that and dealing with, you know, perhaps other issues within the conflict, but really addressing it and pulling it out and really developing strategies and tools for managers to mitigate and avoid those kinds of conflicts. So lots of work that's that we've done, and then also lots that we're planning on doing.
Thank you for sharing, Bertha. It looks like Barth Clinic does, and so does Merit. So that's great. Carol, did you have any closing comments or anything that you'd like to say?
No, I think that we covered a lot of information. We saw a lot of presentations, and thanks everybody for joining us. And I didn't know, Diane, if you wanted to take this opportunity to introduce our new executive director.
Sure. So Greater Columbia now has a new executive director. Her name is Sharon Brown. Sharon, do you want to introduce yourself to everybody?
Hi, everyone. My name is Sharon Brown. You probably know me as the outgoing state senator for the 8th Legislative District, and I'm the incoming executive director for GCACH. I've had the great opportunity of being able to work with the current executive director, Carol Mosier, for the past couple of years on certain issues that GCACH was trying to promote, and it's really exciting to be here, and I'm really thrilled to be working with everyone.
Thanks, Sharon.
All right, so there's a link in the chat. We would really appreciate if you guys could please do the survey. Next month's Learning Collaborative is going to be on December 9th, and it is going to be Blue Mountain Heart to Heart and Consistent Care, and they're going to be doing some tips and tools for treating and managing patients with opioid use disorder. So we hope that you can join us for that. The registration is on our calendar, and so you can register there. But we really appreciate you guys being here with us today. We have our contact information on there, and then we also provided quite a bit of resources. So just so you guys have it, there's a whole toolkit that I thought was so amazing. So I put the link there, and then there's a bunch of other references that we used as we put together this presentation. So these will be available for you after this program. So we really appreciate you guys being here today, and we hope that you have a great Friday and a great Thanksgiving time, as it's that time of year, and a happy holiday. So thank you so much for being here.
Thank you.